হ্যালো,
আসসালামু আলাইকুম স্যার।
শুনতে পাচ্ছো?
ইয়েস স্যার।
আচ্ছা, আমরা in the last class we tried to discuss about some of the features of chronic cholecystitis. Definitely you can remember chronic cholecystitis may be of two form, chronic calculous cholecystitis and chronic acalculous cholecystitis. And patients are usually presented with pain in upper right abdomen. This pain might be colicky in nature to dull aching, may radiate to back of the chest or inferior angle of the right scapula associated with hello শুনতে পাচ্ছ তোমরা?
ইয়েস স্যার।
Associated with flatulence, dyspepsia, feeling of fullness after meal. On examination, finding is usually negative other than the deep tenderness in the right hypochondrium. And on this clinical ground, diagnosis may be confirmed by doing an ultrasonogram, which shows gallbladder is smaller, contracted. It contains one or more echogenic structure, casting posterior acoustic shadow. And other investigation we usually do for assessment of the fitness of the patient. And ultimately, we do the cholecystectomy for the treatment. And usually, the procedure is laparoscopic cholecystectomy. ঠিক আছে?
ইয়েস স্যার।
In another form, whenever the stone is present or sometimes stone may not be present, there is another form of presentation of the disease is with acute cholecystitis. So acute cholecystitis means the acute inflammation of the gallbladder. And in 80% cases, acute cholecystitis results from obstruction of the cystic duct by gallstone impacted in the Hartmann pouch and gallbladder become inflamed and distended. So আমরা যখনই acute cholecystitis দেখি তার 80% ক্ষেত্রেই it is associated with gallstone, and this stone temporarily going to impact the cystic duct or neck of the gallbladder. এবং আমরা দেখেছি in most of the cases, in 90% cases, these attacks will be resolved spontaneously by conservative treatment with dislodgement of the obstruction and release of infected bile. So whenever we consider the acute cholecystitis, we can say that it is of two types: acute calculous cholecystitis, that is in 80% cases it is associated with stone usually present in the gallbladder, and attack is started when the stone going to impact the Hartmann pouch or cystic duct. And in remaining 20% cases, though there is acute inflammation, gallbladder wall is distended, wall is thickened, but there is no stone. So this group is called acute acalculous cholecystitis. So in acute cholecystitis, why there is inflammation, or if one say the gallstone is being associated with inflammation, naturally question may raised why this gallstone is responsible or how it is responsible for development of the acute inflammation. Some of the known factors related to that is number one, obstruction of the cystic duct. So in acute cholecystitis, in most of the cases, at least in 80% cases, gallbladder will be distended and inflamed because of the obstruction of the cystic duct. Second factor related to acute inflammation, because of the presence of the gallstone, it releases the phospholipase from the mucosal cells of the gallbladder. So by the repeated minor trauma with the gallstone, it releases the phospholipase enzyme from the mucosal cell of the gallbladder. And this is followed by conversion of the lecithin in bile to lysolecithin. And this lysolecithin is toxic and cause inflammation. So second factor related to acute inflammation, যখনই gallbladder stone থাকে, it causes a minor trauma to the mucosal wall. Mucosal wall কে যখন trauma করে, তখন there is release of phospholipase. Phospholipase যখন release হয়, তখন বাইলের মধ্যে যে lecithin থাকে, that is converted into lysolecithin by the action of the phospholipase. And this lysolecithin is one of the mediators for acute inflammation. And thirdly, whenever there is distension of the bladder, when there is initiation of the inflammatory process, the bacteria that is already present in the bile might take the opportunity to invade the wall and lumen. So in acute cholecystitis, all the three, there is obstruction of the cystic duct by the stone, trauma from the gallbladder which releases the phospholipase, and lastly, secondary bacterial infection. It may be gram positive or gram cavity negative. So all these three factors are ultimately responsible for acute inflammation, that is acute cholecystitis. Acute acalculous cholecystitis, A means no. You could understand in these categories, there are all features of acute inflammation, but there are no stone present in the gallbladder. Here, the inflammation is related to some of the known factors. Number one, obstruction of the cystic duct by stricture or tumor. If there is obstruction of the cystic duct other than the stone, that is like by the stricture or tumor, the same sequelae can follows. Primary bacterial infection, if the bacterial infection is severe enough, that might be responsible for acute inflammation like Salmonella, Clostridia, E. coli. Specific inflammation, we have already mentioned in chronic cholecystitis, cholecystosis, that is there are morphological changes in the wall of the gallbladder in the form of cholesterol deposition, cholesterosis, development of multiple polyposis, proliferation of the glandular adenomatous tissue, that is adenomyomatosis, and the cholecystitis glandularis proliferans, there is proliferation of the all component of the gallbladder wall. So this is a category, special categories of morphological changes that might be responsible for either acute inflammation or chronic inflammation. Next one, cystic artery occlusion. Whenever there is occlusion of the cystic artery, there will be relative ischemia, and the relative ischemia might be responsible for inflammation. Acute illness, major trauma, major surgery, burn, total parental nutrition, all these might be responsible factors. So in this situation, there are no stone, but there might be obstruction of the cystic duct, maybe primary infection by E. coli, Clostridia, Salmonella, maybe specific inflammatory changes in the form of cholecystosis, cystic artery occlusion, or after a major illness, major trauma, major surgery, severe burn, and total parental nutrition. In this condition, the gallbladder may be inflamed in absence of stone. So this is called acute acalculous cholecystitis. So how the process is going on in acute inflammation? Already we have mentioned it is usually started with the obstruction of the cystic duct. So when the cystic duct is obstructed, the content of the gallbladder cannot flow into the bile duct and into the intestine. So gallbladder become distended and it become inflamed. After few days, if the obstruction is relieved, inflammation resolve, and and inflammation largely resolved within 4 to 6 weeks. So usually whenever there is obstruction at the neck, there is distension of the bladder, gallbladder, and the stone slips away from the wall because of distension and go back into the cavity, and the obstruction is relieved. With this, it usually takes 4 days, 4 weeks, and ultimately the attack will be resolved. But sometimes obstruction is going to persist, and if it persists, it develops empyema, that is accumulation of pus. It might develop gangrene, or in the gangrenous part, there is development of perforation. So gangrene and perforation may occur as early as 3 days, but most perforation occur during the second week of initiation of the acute inflammation. Pathological changes, first change, there is subserosal edema and hemorrhage, patchy mucosal necrosis. So in acute inflammation, there is edema of the subserosal region, and there is microhemorrhage and patchy mucosal necrosis. Later on, there is polymorphonuclear infiltration. And finally, there might be ischemic necrosis and gangrene, or if resolved, fibrosis with chronicity. Here, in acute inflammation, gallbladder will be distended, surface is shaggy, that is not smooth. It is dull white in color. Wall is thick and edematous. So if we see the cut section or cut specimen of the gallbladder, we can see this is being affected by acute inflammation because gallbladder appeared to be distended. Surface is shaggy, dull white in color, wall is thick and edematous. What would happen if the patient is not under appropriate treatment? So there are some sequelae and complications. Number one, resolution of acute attack. Commonly, if we start conservative treatment, even without conservative treatment, in most of the time there is dislodgement of the stone and drainage of pus, and attack will be resolved. So this is the common sequelae. Second is empyema of the gallbladder. If the obstruction at the neck of the gallbladder is going to persist, the infected material cannot drain out. There will be accumulation of pus in the gallbladder, and the condition is called empyema of the gallbladder. And lastly, there might be gangrene, necrosis of part of the gallbladder because of lack of blood supply. And if there is necrosis and presence of distension, a part will perforate with the discharge of content in the peritoneal cavity. That ultimately leads to localized perforation, leads to pericholecystic abscess. Perforation produce generalized bile. It will produce fish. If there is gangrene and perforation, It the content can be accumulated around the gallbladder, that is pericholecystitis. It might freely flow into the whole of the biliary peritonitis, very severe condition and with high mortality. And sometimes a part of the gut remain adherent to the inflamed gallbladder, and there is free perfusion produce cholecystoenteric fistula. How we can make the diagnosis? Definitely, disease diagnosis is based on history, physical examination, and investigation. In the history, we can observe there is sudden attack of pain, that is in contradiction to chronic cholecystitis. Here the patient is almost all right. Suddenly she or he develop severe pain in upper right abdomen. This pain is very characteristic, severe enough that kept the patient in bed. Patient going to the rest. He or she cannot do the normal activities or work with this pain. Pain is so severe. So severe attack of pain. And this pain is persisting hours to days. Definitely biliary colic in chronic cholecystitis. Already we have mentioned that pain usually persisted for minutes to hours, not more than 12 hours. But in case of acute cholecystitis, pain persisted for hours to days, definitely at a stress more than 12 hours. সুতরাং যদি কোনো পেশেন্টের ব্যথা থাকে রাইট হাইপোকন্ডিয়ামে যে এক নাগারে 12 ঘন্টার বেশি, তাহলে the nature of disease will be acute cholecystitis. This pain usually referred to right tip of the right shoulder. আমরা জানি from the, if there is acute inflammation, there is formation of exudate and there is irritation of the diaphragm. So by the irritation of the diaphragm will be irritated and patient feel pain, report pain to the fourth cervical segment, and that is being represented the tip of the right scapula, and that's why patient complains of pain to the tip of the right scapula. আমরা দেখছি in chronic cholecystitis pain is confined within the wall of the gallbladder, and we know gallbladder is innervated by 10 thoracic sympathetic segment. এই জন্যই referred pain will be felt at the inferior angle of the right scapula, but in a cholecystitis pain will be referred to the irritation of the diaphragm, and diaphragm is innervated by the 3, 4, 5 cervical segment, mainly 4, and 4 represent the tip of the shoulder, and that's why the pain will be referred to tip of the right shoulder. And this pain will be aggravated on food, more with fatty food. This is associated with like other acute inflammation, nausea and vomiting, and in 10% cases there might be jaundice even. Here this jaundice is not due to hepatitis or not due to obstruction of the bile duct. It is mainly due to associated cholangitis. Whenever there is inflammation of the gallbladder, the adjacent bile duct will also become infected, and the mucosal lining will be thick and edematous, and there will be some sort of stasis, and the patient will be cholangitis. So in acute cholecystitis present with sudden attack of pain, the pain is severe, persisting for more than 12 hours at a stress. It is in the right hypochondrium. The pain is referred to the tip of the right shoulder. In it aggravated after taking food, and it is associated with nausea, vomiting, and fever. In 10% cases, this attack of pain is also associated with jaundice. On clinical examination, whenever we're going to examine the patient, there will be manifestation of acute inflammation onto the system, onto the abdomen. That is, on general examination, patient appear ill and anxious, temperature will be raised, pulse rate will be correspondingly raised, patient mild jaundiced. So patient is ill and anxious, temperature will be increased due to acute inflammation, pulse rate is raised, because we know for every degree Fahrenheit of temperature, there is rise of pulse rate for 10 beats per minute. So if there is proportionately rest, and there might be mild jaundice, want to examine the abdomen, there will be tenderness and rigidity in the right upper quadrant. তোমরা নিশ্চয় জানো যে acute inflammation of the abdomen, there is related 4 sign. Tenderness means pain on pressure. Rigidity means a state of involuntary tautness of the muscle. Muscle guard means increasing tautness on pressure. Whenever you are giving pressure, more taut. And rebound tenderness, that is pain felt on releasing the pressure. So if there is any inflammation at a particular area of the peritoneum or whole area, the area shows the features of inflammation like tenderness, rigidity, muscle guard, rebound tenderness. Second, the most important is Murphy's sign. Murphy's sign is positive, and definitely you know we try to demonstrate this sign by the left hand, by our left hand. We have to place our left hand in a way so that thumb will be just below the tip of the 9 costal cartilage, and other fingers remains across the anterolateral aspect of the costal margin. And we have to gradually press in during expiration, and we have to keep our thumb stationary during inspiration. And during respiration, particularly during inspiration, as the diaphragm moves up and down, along with the liver moves up and down. So at the height of inspiration, the diaphragm, liver, and the gallbladder will come at the lowermost level, and we can feel or able to touch the inflamed gallbladder by our thumb. And at that time, patient at the height of inspiration, because to prevent the further pain. This is called Murphy's sign. So Murphy's sign will be positive in case of acute cholecystitis. Sometimes pain is so severe that it is not wise to demonstrate this sign, causing severe tenderness that is more than Murphy's. So it is not wise, not necessary to demonstrate the Murphy sign. And sometimes the gallbladder may be palpable, or there is a mass-like lesion in the right hypochondrium. Amra boli abdominal phlegmon, that is inflamed, and there is development of a faint lump in the right hypochondrium. That is also features of acute cholecystitis. So in acute cholecystitis, on general examination, patient will be ill, anxious, temperature is raised because of inflammation, pulse rate is raised because of increased temperature and cause of associated cholangitis. You can get tenderness and rigidity in the right hypochondrium. Gallbladder may be
স্যার
some
স্যার সাউন্ডের প্রবলেম হচ্ছে স্যার।
which is tender also. Hello?
স্যার আমরা কিচ্ছু শুনতে পাচ্ছি না স্যার,
Hello?
নেটওয়ার্কের সমস্যা হচ্ছে স্যার অনেক।
স্যার নেটওয়ার্কের সমস্যা হচ্ছে স্যার।
সমস্যা শুনতে পাচ্ছ না, এটা কি ফ্লাকচুয়েটিং সাউন্ড নাকি কনস্ট্যান্টলি ইট ইজ লো সাউন্ড?
স্যার আটকে আটকে আসতেছে স্যার, কথা সাউন্ড শোনা যাচ্ছে আবার শোনা যাচ্ছে না।
Throughout this period, whole period the same নাকি এখন মনে হচ্ছে?
স্যার ফার্স্টে স্যার ভালো ছিল স্যার, এখন স্যার আস্তে আস্তে খারাপের দিকে চলে যাচ্ছে।
Can you see the slide? Hello? তোমরা কি
জি
দেখতে
স্যার, স্লাইড
পাচ্ছ?
দেখা যাচ্ছে স্যার,
জি স্যার,
স্লাইড দেখা যাচ্ছে, বাট স্যার
দেখতে
সাউন্ড
পাচ্ছি
শোনা
স্যার।
যাচ্ছে না স্যার।
আচ্ছা ঠিক আছে, তাহলে আমরা হচ্ছে whenever we make the clinical diagnosis as acute cholecystitis, we have to do some investigations to confirm the diagnosis and to assess the condition of the patient. You see, the most important one is ultrasonogram of the hepatobilium and pancreas. This is the most important. It shows the gallbladder is distended, wall is thick, and it contains one or more echogenic structure casting acoustic shadow. Other investigation like HIDA scan, plain X abdomen, this is not very important and usually not done routinely. But do the routine blood test like TBC, liver function test, টাইম শেষ। আচ্ছা, শুনতে পাচ্ছ? শুনতে পাচ্ছেন না? হ্যাঁ
স্যার কথা কেটে কেটে আসতেছে। গুড
স্যার লেফট নিছি।
ক্লাস অফ করে দিই। শুভ্র ভাই কি করে ভাই? শুভ্র ভাই
স্যার আপনার মাইক মিউট করা স্যার।
স্যারের ইয়া খোলা, ভিডিও অন করা, এটা আবার কি স্টাইলে বুঝলো, ইয়া করে দিতে পারতো।
হ্যালো, শুনতে পাচ্ছো? হ্যালো,
জি স্যার।
যেহেতু শোনা যাচ্ছে না ভালো, নেটটা ভালো নাই, আজকে আমি এখানে শেষ করছি। উইল কন্টিনিউ দিস ক্লাস in the next time. Okay, thank you.
Yes, sir.
जी सर, आदाब सर।
ওকে, আমরা এখন ল্যাব নেই।